radiographic appearance of emphysema. So with emphysema, you get hyperinflation of the lungs, really long, dark lungs. With hyperinflation, you can get a flattened diaphragm because the lungs are just so overly full of air. You might see blebs, like here they're showing you the wall of a bleb here. There's another one here. Just these large linear lines are the walls of those giant air-filled spaces. And then increased retrosternal airspace. Again, the heart is actually being separated from the sternum because there's all this air in the lungs that is actually pushing the heart and the sternum away from each other. So with all this hyperinflation, what this means for you as the tech, if you're x-raying somebody who has emphysema, that is going to be a very destructive pathologies. There's a lot of pathologies we talk about in class that are like, maybe you need to go up a little, go down a little, depends on severity. Emphysema is a big technical factor adjustment. So you're going to make a large compensation with your technique when you have somebody who has emphysema. So it's a very destructive pathology. That means you need to go down in your technical factors. And it's a significant drop in technical factors, especially with like end-stage emphysema, very significant increase in technical factors. Other things to consider as the tech is how you're going to orient your film. These patients have very long lungs. So when you're doing your PA, instead of going a crosswise orientation, you should probably consider going lengthwise if you can make the patient fit, because the lungs tend to be really long. If they're wide and long, then you're going to need to do two, like an upper and a lower shot. Also to consider in the lateral is you may need to do your lateral crosswise, because the chest tends to be this barrel shape with hyperinflation. So you can have a really wide chest when you turn the patient laterally. So you may actually have to do a crosswise lateral to compensate for the shape of the patient's chest. Other things to consider, I don't have it on here, is emphysema patients also have, they don't have a lot of endurance. So you need to consider that when you have, particularly an outpatient with emphysema, how far are you going to make them walk down the hall? Maybe they should have a wheelchair. Maybe you need to call transport to help them leave, go back to their car. They might even need help changing. Like if their endurance is so low, they can get really winded just changing their clothes. So always be conscious of, what shape your patient is in and what you're going to be asking of them. Okay, so that's it for emphysema. So we're still covering COPD. So remember, COPD had 4 conditions. It had chronic bronchitis, emphysema, asthma is the next one that we're going to talk about under the umbrella of COPD. So I think most people kind of have heard of asthma, know what asthma is. Maybe you know somebody with asthma. Maybe you have asthma. It's pretty common. So what asthma is there's going to be widespread. That means both lungs are going to be affected. So it's going to happen across both lungs. The bronchial walls are going to swell. That's going to decrease the amount of airspace in the lumen of the bronchial. And you also get spasm of the muscle component of the bronchial wall. So your bronchial wall has a circular muscle component, and those are going to start to spasm, and that's going to further narrow the bronchial airways. With this, there's going to be an increase in mucus production. So mucus production will go up, and the lumen of the airway will become more and more reduced. As that happens, you might hear your patient starting to wheeze as air is trying to go in and out of these really narrowed airways. It can lead to total airway obstruction. If that swelling and spasm of the bronchial wall becomes intense, you can actually have total obstruction of the bronchial airway. Things that can kind of trigger an asthma attack. So things that can lead somebody into an asthma attack. Allergens can do it. So anything that you're hypersensitive to can lead to asthma coming on. So stimuli can do it. Allergens, you can get exercise-induced asthma. So somebody might start having asthma as they're exercising. Temperature changes, and it tends to be going from warmer to cold. So cold air tends to do it more, can kind of trigger that spasm and cause an asthma attack. And even emotional upset can actually induce an asthma attack. So if somebody gets really upset, that can kind of trigger them to go into an asthma attack. Okay, so diagnostic tests that we can do. First one is just a chest x-ray. A chest x-ray isn't really great for asthma, but it often is done when somebody is having an attack of breathlessness. Not so much to diagnose asthma, but to rule out any other pathologies that might be causing breathlessness. So a lot of times that chest x-ray will be done, even though knowing with asthma it often is going to be negative. Other tests for diagnostic purposes is spirometry. Remember, we talked about pulmonary function testing before. So this is when they're going to have the patient breathe in and out of a spirometer. They're going to measure total inspiratory volume, expiratory volume, total lung volume, how quick or slow they breathe in. All of that can help kind of aid in the diagnosis of asthma. And then just a history and physical exam. So the doctor's just going to talk to the patient, you know, how did you feel? What stimulus did they have that triggered it? Will also help lead to the diagnosis of asthma. Okay, so what it looks like radiographically, 75% of the time, you're going to get a negative chest x-ray for asthma. So that means only 25% of the time you can see asthma on an x-ray. So it's not a great test. Chest x-ray is not a great test for asthma. But like I said, you're trying to rule out other causes of breathlessness before you can come to the diagnosis of asthma. So you need to exclude all the other things before you can go, okay, it's probably asthma. If the film is taken during an attack, so someone is right in the middle of a massive asthma attack, or if they have chronic asthma where they have frequent attacks, and also that can lead to frequent lung infections, those are the things that you're going to see on x-ray. But like I said, 75% of the time, the x-ray will be negative. If you do happen to take an x-ray during an asthma attack, things that you might see are hyperaeration of the lungs. So much like with emphysema, you're going to see the lung tissue itself will appear darker. So the parenchyma will be darker, the diaphragm will be flatter, and you'll have a longer lung. So there's going to be more lung volume. And that's because same thing, it's easier to take air in than it is to expel air passively through those reduced passages for airway. So air gets trapped in the lungs, so you're going to get a lower flat diaphragm and increased retrosternal airspace as the lungs kind of hyperinflate. What you won't have, though, it's not going to look like emphysema, though, because you're not going to have any alteration in blood flow like you get with emphysema, and you're not going to see any blebs or bulla. Another thing that you can see on x-ray is if somebody has frequent attacks. So chronic asthma, many attacks can lead to also frequent lung infections, and that will cause that dirty lung appearance where all those little tiny bronchioles that otherwise you're not going to really appreciate on x-ray, now you're going to start to see them because they are thickened with mucus. So that's going to make them more prominent. So we call that dirty lung appearance with increased bronchial marking. Okay, so this is a patient who has chronic asthma, and you're going to get the dirty lung appearance. So as you look out, I think it shows up well over here on this side of the lung. Just overall, there's an increase in lung markings than you would see on a normal healthy x-ray. So little tiny bronchioles that otherwise you wouldn't appreciate. I can now see them because they're all thickened. And fibrosis can happen with frequent infections. And remember, fibrosis happens from like healing. So it's kind of like a scarring from healing. And with fibrosis, it tends to start in the hilar region and then go out and up. So there's like a pattern of linear markings that go from the hilar region out and up. And you can kind of see that here, starting in here, and you'll see all these linear markings going out towards the periphery. And that's it for asthma. And then the last one I want to talk about is bronchiectasis. So this is the last condition that kind of follows under the COPD umbrella. So what bronchiectasis is it's going to be, it's an irreversible dilation of the bronchi. With bronchiectasis, the elastic and muscle components that kind of hold the bronchial wall together become weakened, and they allow the bronchi to kind of become expanded. So they lose elasticity in the walls, they kind of widen out. And then you can get retained mucus. It's harder to expel mucus out of these bronchi now. So you'll get retained mucus inside the diameter of the bronchi. It tends to happen in patients who are immune suppressed, are going to be more susceptible to bronchiectasis. And it can then lead to more lung infections. Cystic fibrosis are some patients who are more susceptible to bronchiectasis because they can't expel that all that excess mucus, and then that leads to frequent lung infections, and then the frequent lung infections lead to bronchiectasis. The incidence of bronchiectasis has gone way down with the use of antibiotics and vaccines. It's not as common as it once was, but immune suppressed patients are still more susceptible to bronchiectasis. Okay, this is just a picture to kind of show what's happening. So if you look at the overall lungs here, you can see the upper lung fields kind of have these nice pink, not too big diameter bronchial passageways. But in the lower lung fields is where bronchiectasis tends to be worse. And you can see the bronchial diameter has widened. The muscle component is gone. So there's breakdown of the muscle and elasticity of the wall. And then the wall itself is actually thickened. So you have a thickened wall, an increased diameter of the bronchial tree, and then a loss of the elastic components that kind of hold everything together. And that is allowing all this mucus to be retained in these widened air spaces. Okay, so diagnostic tests you can do just a chest x-ray. You can do a CT chest, and notice it's a high resolution CT. So that's going to be a thinner cut. That's more to look at the parenchyma of the lungs. And currently, this is now the test of choice to diagnose bronchiectasis. Other tests that can be done is, again, pulmonary function testing using like spirometer and, O2 levels of the blood. They're going to test all that to see how well the patient is oxygenating their blood. Bronchography or a bronchogram can also be done and also will provide definitive diagnosis. However, I'll bet none of you have seen a bronchogram. It's still in the book. It is becoming a more obsolete test. CT is kind of taking the place of doing a bronchogram. I haven't seen a bronchogram since I was a student, and that was a long time ago. So very rarely is a bronchogram done. Bronchoscopy can also be added to this list of tests to be done, but that's more to kind of follow the patient's course of disease. If a patient is not responding to treatment, they might do a bronchoscopy where they go with a camera down into the bronchial tree to look at the bronchial tree. But CT really has taken over as the diagnostic tool to really diagnose bronchiectasis. A bronchogram, I just want to talk a little bit about that. A bronchogram, what it is they go down the trachea down into the mainstem bronchi with a catheter, and they inject an oil-based liquid contrast. And as they're injecting, they have the patient do a really quick, short inspiration, like that. And what that does is it pulls that contrast down into the bronchial tree, and then it coats the bronchioles, and then you can see them on radiograph. So that's how a bronchogram is done. And then the patient can cough out. It's an oil-based contrast. A long time ago, it's called Dionysil. I believe that's what it was when we did it. And then they cough it back out again, and you can suction it out again. Okay, so what does bronchiectasis look like on X-ray? And this goes for both CT and for a chest X-ray. The findings are going to be, usually it's the basilar segment of the lungs. So the lower lobes tend to be more involved than the upper lobes. Doesn't mean the upper lobes can't be involved, but tends to start in the lower lobes. About half the time it's bilateral. So you might see it in both lungs. And you're going to see coarsening of interstitial markings. So all the markings around the air spaces can appear more dense. And then the air spaces themselves are going to be enlarged. So all of these little round black circles you're seeing are actually bronchioles. that have become dilated and are now full of air. And then notice the walls around them are thickened and more obvious. So for example, if you look at just this section of lung right here, pretty normal looking, normal size to the bronchial spaces, normal interstitial markings. Here, the interstitial markings are very white, they're very dense, and then the air spaces are very large. And they call this a honeycomb pattern, and that means the walls of the honeycomb are those interstitium that's increased in density, and then the center of the honeycomb is going to be those widened air spaces. So that's what you'll see on CT and chest X-ray. On a bronchogram, now those air spaces are filled with contrast. Patient has inhaled the contrast, so you're going to see just a large dilation of the bronchial system. Okay, so here is just a little piece of a chest X-ray, and I liked this one because it really shows you those large cystic spaces. So if you look at this, you can see there's one here. So the wall is thickened, so I can actually see the bronchial wall because it's so thickened, and then there's an air space in the middle. If you really start to look, you can see, oh, there's one here, there's one here, one here. So you'll start to see all these little circles, which are those really widened bronchioles surrounded by a thickened bronchial wall. Coarsened interstitial markings, again, the wall is thicker and it looks coarser, more dense. And then let's start with this one. So another chest X-ray. I like this one because I think it shows you the honeycomb pattern really well. If you look in the upper lung lobe on this one, I think it shows up the best up here. You can see all these little circles that are these dilated air spaces, and then the wall around them are thickened. So it gives you that real honeycomb pattern. Big ones right here. And then this is a bronchogram. So this, you can see the catheter coming down. They've injected contrast. Patient has inhaled the contrast deep into the bronchial tree. And you can see really in the lower part of the lungs just how big and wide those bronchioles have stretched out. So this is like a breeding ground for bacteria. So it's very likely that this patient will have multiple lung infections with the bronchial tree being this dilated. And again, this contrast, once the test is over, the patient coughs and they can also suction it out. One thing to talk about on this, I said we use an oil-based contrast. This goes back to just contrast in general, something that you should know. Hopefully you probably have already talked about this, is whenever someone is at risk for aspiration, you do not want to use a water-based contrast. Most people think, oh, water-based, that sounds better. That sounds way less harmful. But water-based contrast is like gastrographin, those things have a chemical makeup that will actually, they're called hydrophilic. So that means that in the presence of water, they pull water towards them. So if I was going to put a hydrophilic contrast down the respiratory tree, it's going to attract fluid and it's going to pull fluid into the lungs. So this person will then become very sick. They'll have a rip-roaring case of pneumonia. So you don't want to aspirate a water-based contrast. So for example, when I don't know if we talked about this before, doing a cookie swallow. Oh, for aspiration. If someone's at risk for aspiration, they might do a cookie swallow on them. They're going to use barium if they think the patient might aspirate, not gastrographin. Because if the patient aspirates barium, it's inert. It's not going to interact with anything, and it can be suctioned back out again. So don't want to use a water-soluble contrast in the chest. The opposite is kind of true, though, for the bowel. When we get into the bowel and using contrasts like for GI studies and stuff, if someone's at risk for perforation, you want to use a water-soluble contrast, because if it goes into the peritoneal cavity through a perforation, it can be reabsorbed. So if I have someone who's at risk for perforation, should I give them barium, which is this inert substance? If it leaves the bowel and goes into the peritoneal cavity, it's going to stay there, right? It's not going to be reabsorbed. So it depends on what part of the body you're working in. So in the chest, if there's a risk of aspiration, do not use a water-soluble contrast. In the bowel, if there's a risk for perforation, do use a water-soluble contrast. So that's just a little important thing to remember, side note. Okay, back to bronchiectasis. Again, here's the honeycomb, a real honeycomb, and you can compare that. This is a high-resolution CT chest. This is just a little cut out of this film. And you can really see thickened walls, big dilated cystic air spaces where those bronchioles have stretched out. And then this is another patient, just has a widespread overall interstitial thickening that you can see here. If you look closely, you can see there's some widened air spaces, but on this particular film, there's just a lot of thickened interstitial fibrosis, not fibrosis, thickening of the interstitium. Okay, so keep this X-ray in mind. And now let's talk about radiographic considerations. It is an additive pathology. Even though we're getting these widened air-filled spaces, that destruction or destructive pathology doesn't overcome the increased interstitial markings, so the thickening of the bronchial walls. So it's still an additive pathology. So you still need to increase your technical factors. Okay, so that's it for all the pathologies that go under COPD. We're still talking about diffuse lung diseases though. So there are more diffuse lung diseases, but no longer part of COPD. So the next class is called the pneumoconiosis. So these are also called the dust diseases. So what, excuse me, what that tells you is these are going to be diseases that happen as a result of inhaling some kind of particulate material. And what that material is depends on what type of dust disease you will get. So what is a pneumoconiosis? It's several diseases. It's not just one that causes a chronic inflammation and fibrosis of the pulmonary tissue after exposure. And the exposure tends to be ongoing, prolonged exposure. Often it's occupational exposure to some kind of particulate matter. There are a lot of dust diseases. I'm going to talk about the most common ones. There's 3 we're going to cover in class. First one is silicosis, asbestosis, and then anthracosis. So silicosis is going to be caused by inhalation of silica. This often happens with people who do sandblasting for a job. Asbestosis tends to be like construction workers who have worked with asbestos or remediation of asbestos if you're trying to take it out. And then anthracosis is also called the coal workers disease, coal miners disease. It's also called black lung because it actually turns the lungs black. So this is going to happen more in coal workers. So inhaling coal dust. Okay, diagnostic tests, and this goes for all of the dust diseases. You can do a chest X-ray and a high-resolution CT of the chest. And what you, the tech, need to consider is all pneumoconiosis is additive. So all 3 of those, all of them are going to be additive, and you need to go up in your technical factors. So I'm not going to talk about this per disease because it covers all of them. And since we're in the chest, what technical factor should you go up in? It's going to be mass because we're in the chest. Okay, so first one I'm going to talk about is silicosis. So that's going to come from exposure to silica dust. And like I said, this happens in workers who occupationally sandblast. Death from silicosis can happen from lung or heart disease because you can get heart failure along with failure of the lungs with silicosis. The book talks about how quickly someone can develop silicosis, and they talk about how in somebody who is sandblasting in an enclosed area, unprotected, they can develop this disease in as short as 10 months of occupational exposure. And then people who are have a less intense exposure to silica, it can take 15 to 20 years of occupational exposure to manifest this disease. So depending on the level of exposure, how quickly someone will develop silicosis. Okay, what does it look like? So the findings for silicosis, there's a couple different appearances. First one is going to be miliary nodules. That's not what you're seeing on this x-ray. So think back to miliary TB. Those are those tiny little seed-like nodules that are widely scattered throughout both lungs. Silicosis can look the same way, but the nodules tend to be a little bit more well-defined and a little brighter in their shade of gray. So they're more white than you would see with TB, miliary TB. Another manifestation is the hilar lymph nodes can be affected. So you can have enlargement of the hilar lymph nodes, and they can also calcify. And that's what you're seeing here. This is called the eggshell sign. So the lymph nodes have become large in the hilar region, and they also are starting to take on calcification, which is all these white little speckles you see within the lymph node. And then think to the miliary. With the miliary manifestation of silicosis, if all those little nodules start to conglomerate together, they can start to stick together, and you can get one big irregular mass. So as the nodules kind of coalesce into this one mass, that can happen as well with silicosis. So get one big, large, irregular mass. So this is silicosis looking in that miliary pattern. So you'll notice it's diffuse, it's both sides. The nodules are teeny tiny little things all over the lungs, but they're pretty well defined, and they're much brighter and whiter than you would see with like miliary TB. So really bright white nodules. Looks like a really high contrast x-ray. Okay, so the next dust disease that we'll talk about is asbestosis. So this, whoopsie, it's going crazy. This happens with occupational exposure of asbestos. So this happens more in construction workers, pipe fitters, anyone that works with building materials, particularly that were made before 1980. So 1980 is when they said, hey, let's not put asbestos in building materials. It's actually really bad for you. So pre-1980, construction had a lot of asbestos. And then now there's people who remediate and try to remove asbestos. So they could also be exposed to asbestos. And they have to wear lots of protective primary protective gear to keep them from inhaling the dust from asbestos. What happens with asbestosis is the fibrosis happens now in the pleura. So it's actually the pleura lining of the lungs that gets affected by asbestos exposure. And there is a tumor called mesothelioma. You might have seen this on TV. I see lots of like class action lawyer commercials. If you have mesothelioma, call this number. Mesothelioma is a cancer. It's a malignant tumor. It's based from pleural tissue, and it tends to happen with people who have been exposed to asbestos. Asbestosis is not a cancer, but it can correlate with mesothelioma, which is a cancer. And it's a very malignant tumor of the pleura. Okay, so what does asbestosis look like? Now it's the pleura that's affected. So the pleura actually becomes kind of calcified. So you get a calcified pleural plaques, and they can look just like thickened curvilinear densities when you see them in profile. And that's what these yellow arrows are pointing to. So we see this curvy line here, here. There's another line right here, kind of a little bit below where you can see on the diaphragm. So that's just this calcification of the pleura itself. And this other pattern that the red arrows are pointing to is called the holly leaf sign. And this is just a wide calcification of area of the pleura. And then on this side, these arrows are pointing to the periphery of the lung, where you can actually see the edge of the lung is completely calcified. The pleura is calcified, and then along the base. And then the arrows with the little stem is pointing to the mediastinal pleura lining, also calcified. So like the entire lung, almost you can imagine it as sort of calcifying. This patient's gonna have a lot of trouble expanding and contracting their lungs, right? If the pleura is kind of stiffened with all this calcification from asbestosis. And then the last of the dust diseases we'll talk about is anthracosis, or the coal miner's disease, also called black lung, which you can see here. The lungs have turned black instead of pink now. On autopsy, the lungs actually have this black appearance. This happens from, again, usually prolonged occupational exposure to coal dust. The coal dust collects in the bronchioles, and it can actually turn the tissues of the lungs black, like you're seeing here. Not a nice, healthy pink. So what does it look like on X-ray? Here, you're still going to have nodules, but they're not the fine little well-defined miliary nodules like silicosis. They tend to be bigger, less well-defined. So I can see like there's one here. There's a bunch of them here, big one here. And they tend to start in the hilar region and then radiate outward. So starts in the hilar region where most of the exposure comes in, and then starts to radiate out towards the periphery of the chest. And again, not well-defined like silicosis. They have irregular borders, so not a nice, well-defined mass. Okay, so that's it for the dust diseases. The next thing I want to talk about is neoplasms, which stands for new growth. And I just realized I forgot to set my timer. So I'm going to do that now. And hopefully I won't talk too long. Set it for... Okay. So neoplasm or new growth. So now we're talking about tumors, benign or malignant. And there are, for the respiratory system, there are three major neoplasms that we're going to talk about. The first one is bronchial adenoma, bronchogenic carcinoma, and pulmonary metastases. So these two are primary lung cancers, and then a pulmonary metastasis can come from anywhere in the body. It could also come from somewhere else in the respiratory system, but it's a primary tumor that has started somewhere else and then has created new tumors somewhere else in the body. Going back to our terminology from chapter 1, I told you can kind of guess if something is benign or malignant based on the name. So here we have bronchial adenoma. So adeno is telling you glandular tissue, and then it has the suffix oma. So this is indicating that it's likely a benign tumor, and bronchial adenoma is mostly benign. It starts in the glandular tissue of the bronchial tree. Bronchogenic carcinoma, anytime you see carcinoma, you know that's a cancer of epithelial origin, and it's originating in the bronchial tree. And then pulmonary metastases means it started somewhere else and then traveled to the lungs. So for all of these neoplasms, they are all going to be additive pathologies, and you're going to need to go up in your technical factors in advanced disease. If somebody has one small solitary lung tumor, you may not need to change your technique. But if they have tumors scattered throughout their lungs, then yes, you'll need to change your technique. So it depends on the how far in the disease process they are, whether or not you change your technique. This is not in the book, but I think it's useful information to have. Just kind of what you can kind of start. You don't know without a biopsy, but you can have hints of whether something is benign or malignant by looking at the nodule itself. So in benign disease, the borders of the mass will tend to be well-defined, smooth borders. Doubling time is the time it takes for a tumor to double in size. So from the moment they see the tumor, how long and it measured, let's say, I don't know, 2 millimeters. How long did it take to get to 4? So that would be doubling time. So if it happens in less than 18 months, I mean, if it takes longer than 18 months for that to happen, 18 months or longer, that is considered a slow doubling time and tends to indicate benign. Also, kind of interesting, a really, really fast doubling time also can be indicative of a benign tumor. So if the doubling time is under 30 days, that does indicate a benign tumor. Presence of calcifications within the mass. This is true except for in the breast. So if you have a tumor and you see calcifications spickled throughout it, it's probably been there for a while, and that can indicate a benign tumor. except in the breast. A lot of times for breast cancers, the very first thing they see for breast cancer is they're called microcalcifications, little teeny calcifications that kind of surround the tumor. Okay, so conversely, malignant tumors have irregular borders. Remember, a cancer that's the Latin word for crab, I think, grabby hands, grabby hands. So a malignant tumor is going to kind of be reaching out into all the tissues around it. So the borders are going to be less well defined. The growth rate is considered medium to fast. And I don't have it on the slide, but the doubling time is like 2.5 to 8 months, I think is considered medium to fast growth rate. Oops, and I think is that everything? Yes, and then no calcifications is on this one. So those are kind of the differences between benign and malignant tumors. So looking at these two, there's a tumor on each one of these x-rays. This one has nice smooth borders, and you can see how this one is spiculated, like it's reaching out into the tissue around it. So this one is benign, and this one is a malignant tumor. Okay, so first, specific pathology for neoplasms is going to be bronchial adenoma. So this is an abnormal growth that comes from glandular epithelial tissue of the bronchial tree. So the glandular epithelial lining of the bronchial tree is the cells that start this tumor, and generally they're benign. The book talks about there's a low-grade malignancy, but for the most part, these are benign tumors. Excuse me. Diagnostic tests you can do a chest x-ray, a CT of the chest, and then a lung biopsy to provide the definitive diagnosis. And the order of how this usually happens is somebody will have a chest x-ray, they'll see a mass. We better look at that more. Let's do a CT. So they'll do a CT to get more information on the mass, and then a biopsy to pull cells out of the mass and then say, okay, this is bronchial adenoma. And then the mass can be accessed different ways. If it's a tumor that's high in the bronchial system, usually they'll use bronchoscopy to access the mass. So they'll go in with a bronchoscope down the patient's bronchial tree with a camera, and then they'll take a little sample of the mass through bronchoscopy. If you have a tumor that's at the periphery of the lungs, not accessible with a bronchoscope, then they'll use CT, and they'll go in and put the needle in under CT guidance and pull cells out like that. Okay, radiographic findings for bronchial adenoma. This is a bronchogram, and I put this in here even though they're not done a lot, because it really shows you how this is a big tumor just smack in the middle of a large central bronchi. So it's got a filling defect, and the contrast is still able to get by and has gone around it to fill the bronchial tree. So usually they're centrally located and often in major bronchi, but they can be at the periphery of the lungs too. If they are centrally located and large, they can actually obstruct airflow. And they can obstruct airflow to a wide section of lungs. Like this could probably be blocking a lot of airflow to the lungs if it completely sealed off this bronchi. You would get atelectasis distal to wherever the tumor is. Mm-hmm. So if air can't get by, the alveoli are going to collapse, and we call that atelectasis. So diminished air within the lungs. It can be a section of whatever area of the lung that bronchi was feeding. It can be an entire lobe. It can be the entire lung. With atelectasis, you get a homogeneous increase in density. So you just get an overall less darkened area of the lung where the alveoli have collapsed and lost that darkening from air. The diaphragm will go up as there's volume loss. So if there's no air in that part of the lung is going to become shorter, and the volume of the diaphragm will raise, and you'll have less lung volume. If you have a tumor that's peripheral, a large peripheral adenoma that doesn't obstruct airflow, you don't have to worry about atelectasis, but you might see one solitary, well-defined mass towards the periphery of the lungs. So without atelectasis, it can look very different. Okay, so here there's two peripheral adenomas. So this is a bronchial adenoma for both these patients. So you'll see it's at the periphery of the lungs. It's a solitary mass, and it's pretty well defined. So we have smooth borders, benign tumor, and there's only one. It hasn't spread all over the lungs. Same thing here. Even it has this little shape to it. It's still pretty smooth borders, and it's at the lung periphery. And then here, the clues to you that this is bronchial adenoma is there's one lesion, well-defined borders, and it's at the lung periphery again. Okay, so the next one is bronchogenic carcinoma. So now we're talking about a cancerous tumor of epithelial origin. So it comes from the mucosal lining of the bronchial tree. That's a primary cancer, and this is the most common type of lung cancer. So it's pretty common in terms of lung cancer. It's actually common in terms of overall cancer. I had it 13%. So this is 13% of all cancers diagnosed in the United States are actually bronchogenic carcinoma. So it's fairly common. It's associated often with smoking or inhalation of carcinogens. That doesn't mean that if you don't smoke or inhale carcinogens, you can't get it. But there's a strong correlation between developing bronchogenic carcinoma and smoking or carcinogen inhalation. And that can be things like pollution or industrial fumes, as well as smoking. The prognosis for bronchogenic carcinoma tends to be poor. If it can be surgically resected, it has an 18% cure rate. And if it can't be surgically resected, then the prognosis is even worse. So pretty grim statistics on this one. Diagnostic tests that can be done. You can do a chest x-ray, CT, and a sputum smear. And then for definitive diagnosis, so actually looking at pulling out cells and looking at them to say, yes, this is bronchogenic carcinoma, they can do a needle biopsy guided either through CT or bronchoscopy, depending on where the lesion is. If it's high in the bronchial tree, you can do a bronchogram. If it's lower in the bronchial tree, then it would be done with CT. A sputum smear can also look at cells. If a patient coughs up like mucus that has these cells in it, that could be a definitive diagnosis. But if they cough up cells and they don't see any of the cancer cells, it's not really definitive for not having cancer. You could still have it and maybe have just not gotten the cells on this in the sputum. So for definitive diagnosis, you need either the CT or the bronchoscopy guided biopsy. Okay, so what it looks like on X-ray has a varied appearance again. So things you might see as an enlarged hilum. The hilar lymph nodes can be enlarged, and also the primary and secondary bronchi can also enlarge if that's where the mass is at. You can see a solitary nodule, just like with bronchoadenoma. However, this time the borders tend to be more irregular. So you'll see irregular borders to the mass. And then you can see atelectasis distal to wherever the tumor is if it's obstructing airflow. So if the tumor is blocking the airflow of the bronchial tree, then you'll get collapse of the alveoli distal in the lung that's being fed by that bronchi. And then cavitation can also happen with this disease. You can get like a big mass and then develop a cavitation inside the mass. So the tissue inside the mass can die. The walls tend to be very thick. An abscess has thick walls too, but this tends to have thicker walls, and they are really irregular looking walls. Looking at this X-ray here, you can see that there is a large mass and it does have cavitation. So it has a more lucent mid portion, and the walls are very, very thick. So really thick walls and kind of irregular with cavitation in the middle. Okay, so here's another patient with bronchogenic carcinoma. And again, kind of has an abscess sort of look to it, but look how thick the walls are. And this one has an air fluid level, which is what the arrow is pointing to. Other things on this X-ray is you're getting one-sided hilar lymph node adenopathy. So the lymph node on this side is becoming large and it's only on one side, and the bronchi is also becoming larger on that side. So unilateral hilar region enlargement. And then same thing here, air fluid level, thickened walls. It's only one mass, but it's irregular. Okay, and then the last one is pulmonary metastases. And again, when you have a metastatic disease, that means it's come from some other area and transferred to a new area, and that's what we call a metastases. So some malignant tumor has traveled either from another place in the lungs or has come from a whole other place in the body and then traveled and started new tumors within the lungs. And different ways that it can spread to the lungs. We talked about this in chapter 1. First is hematogenous spread through the vascular system, lymphatic spread through the lymph system, and then seeding can just come from one part of the lung to the other. And seeding tends to happen two ways. One I have on here through the bronchial system. So if I have one bronchial tumor and now it spreads to another part of the bronchial, that would be seeding. But you can also have a pleural-based tumor. So if I have a tumor in the pleura, it can spread through the pleural space and then transfer to another part of the lung that way as well. Those are both examples of seeding. Another thing I want to talk about is there are some primary tumors in other parts of the body that tend to spread to the lungs. So breast cancer is a big one. So breast cancer through the lymphatic system can drain into the chest and spread tumors to the lungs that way. Other cancers that tend to spread to the lungs, muscle and skeletal tumors, so musculoskeletal tumors tend to spread to the lungs. Urogenital tumors tend to spread to the lungs, like prostate cancer, for example, often goes to the lungs. Colon cancer also often goes to the lungs, and thyroid cancer. So those are some cancers that have a high tendency to spread to the lungs, metastasize to the lungs. Okay, diagnostic tests. Chest X-ray can show the tumor. You can see a lesion on chest X-ray. A CT is often done next just to get more information on the lesion. Does it have a fluid-filled center? Is it solid? So you can get more information on CT than just regular X-ray. Generally then they will do some kind of biopsy. If it's lower in the periphery of the lungs, it'll be a CT guided biopsy. I don't have it on my slide, but if it's higher up, they can do a bronchoscopy guided biopsy. Either one of those provide definitive diagnosis. And then for a PET scan, that's going to show if there's increased metabolic activity. And this can show for distant places in the body. Let me get both of these up there. PET scan and bone scan. Both of these is where they inject that radionuclide. And it'll show hot spots for all the different areas of the body that have increased metabolic activity, right? So even before there's enough tissue damage to be appreciated, you can see that there's an uptick in metabolic activity, which could indicate that there's a tumor there, even if you can't see it yet anatomically on other studies. So that's an advantage of both PET scan and bone scan. PET scan often is done once there is a cancer diagnosis to both grade and stage the cancer. So it's going to give more information on the metabolic activity of the cells, what kind of, I don't know how to say it, what kind of substances they're hungry for, right? Do they like glucose? Stuff like that. So you'll get more information on how to treat the cancer with the PET scan. More information on cellular activity. I'll just say that. Okay, radiographic findings. What does pulmonary metastases look like on X-ray? So depends on how it's spread to the lungs. For hematogenous spread, you're going to usually see multiple bilateral scattering of nodules. So you'll see multiple nodules, usually throughout both lungs. They can be teeny tiny miliary nodules, or they can be great big nodules like cotton ball or cannonball like lesions. Only in about 25% of the cases will there just be one pulmonary metastases. Usually there's more than one. If it spreads through the lymph system, the appearance is often different. A lot of times you'll just get a coarsening of interstitial markings. So the interstitial markings will look more prominent and coarser. And then any lesions are irregular and poorly defined. So it looks quite different. And this can indicate, based on what these look like, what type of spread, how the metastases got to the lungs. So here's pulmonary metastases that have spread through hematogenous spread. So and a clue here is it's bilateral, widespread, pretty well-defined, irregular, but well-defined lesions. So we have well-defined lesions. These are called cannonball or cotton ball lesions. And I like that because it kind of gives you a visual mental picture on what these look like. Sometimes you'll see the word popcorn lesion, like if it has kind of a lobulated contour, it still is a hematogenous spread of pulmonary metastases. And then compare that now here to lymphatic spread. What you're seeing is just an overall coarsening of the lung markings. So bronchivascular markings are more prominent. They have a coarse, roughened texture to them. And again, it's bilateral and diffuse spread to both sides. Okay, and then here is a PET scan that I wanted to include. It's one so you could see a PET scan. So this is a patient who had prostate cancer, and you can see that here. Let me get this up here. There are some hot spots. So this is an area of increased metabolic activity. So right here in the prostate, there is an increased metabolic activity. And you'll notice up here in the lungs, there's 2 spots in the left lung now, which is an area of increased uptake of a radionuclide. That means there's more cellular activity there. So this patient had prostate cancer that metastasized to the lung. Other things you might go, well, what about the bladder? Does this patient have bladder cancer? And the answer is no. The bladder is a natural reservoir for this radionuclide. Same thing, you can see the kidneys are filtering it. Now the bladder is collecting it. So it's normal to have big dark bladder. Same thing up here in the thyroid. It's normal to have more uptake there. So really the hot spots are 2 in the lungs and then 1 in the prostate. So there's more metabolic activity there. The cool thing is you might see these hot spots. I might have taken a chest x-ray and it could have been negative. If there isn't enough anatomical damage to show up on x-ray, you're not going to see it. But you can see the increased metabolic activity. So for early detection of disease, both lung scan, nuke med lung scan and a PET scan are really good for that. So early detection of disease and distant from the primary tumor. Primary tumor is way down here. And we can see there's mets way up in the lungs. Okay, so here's another chest x-ray with hematogenous spread. And the clues there are, again, big cotton ball, cannonball lesions. Here, there's a big conglomeration of lesions all kind of together, but they are pretty well defined and they're scattered bilaterally through both lungs, kind of like fluffy lesions. I think I'm gonna stop there. Honestly, I have no idea how long I've talked for because I didn't set my timer. So hopefully it's about 50 minutes. We will continue on with vascular diseases next.